Thanks for joining us for another episode of HWL Talks, brought to you by HWL. My name's Tommy Benner. I'm your host of HWL Talks. And today we're super excited to bring our listeners Joane Goodroe. I think, Joane, to kind of put you into a box of healthcare would be limiting. So I'm going to let you give your background, and then we can expand from there. But as I think I explained earlier, a healthcare guru, and like I often say on this podcast, probably forgotten more about healthcare than I actually know. So I appreciate you joining us today, and I'm looking forward to talking with you and learning some more about you. So I'll turn it over to you if you want to give some insight as to kind of what got you to here and what's exciting you about healthcare these days.
Back in the 80s, so that makes me very old, I actually got involved in healthcare as a nurse and was head nurse of at Emory University Hospital of Open Heart Surgery. And then we started a heart transplant program. And the first words that ever came out of everyone's mouth that we had never heard before is insurance won't pay for this, so you're going to have to figure out how to save cost. And the problem is nobody knew where costs were or how they were measured or calculated. So it became a passion of mine going forward to look at cost in healthcare. I went and got my MBA to be able to put that in it. And every step along the way, I got involved in very significant cost projects. I actually ended up running one of the first projects Medicare ever took to look at figuring out how to decrease costs. And to this day, I would say it has not been figured out. And it's probably going to be the number one problem that we're going to be facing in healthcare and as customers of healthcare going forward. We're going to have trouble having access to care because the costs are going to be insurmountable.
Yeah. And Joan, will you dive in a little deeper from being a nurse and then, in the administrative side of hospitals and then owning your own business, and then to the stuff I'm really excited to talk about is that gainsharing that came from that. Will you give me a little insight as kind of from the nurse to leadership side of things? Because to make a workforce tie-in here, I was at a conference recently, and it's kind of a generational thing, right? They were saying that the new nurses that are coming on within the first day at orientation, they're like, when do I become the CNO? Right. So it's like
interesting.
Yeah. So so they were like, when's my next promotion? It's like, well, today's day one, so not today. But making that transition from nursing to leadership, and then the big jump to owning your own business, and then really becoming, I don't know, a better way to say it, like a rock star in that cost saving space with, the advent of gain sharing and all the work you did there. So just a little flavor on the changeover from nursing to administration. And then I want to really hammer down on the cost.
How I got into administration very early in my career because no one wanted the job. And they actually asked me to take the job. And I thought, well, how hard could it be to do it? And then I understood why it was so hard. And I think anyone that works with staffing knows it's very, very difficult. But because you're always got shortages, you're always working in that area. But one of the things that became real obvious at that point is they didn't believe nurses really understood budgets. You were in charge of your budget, but you weren't in charge of putting it together. So that's where, to me, I started getting very aggressive into wanting to be part of it. And I stayed on a clinical path and an administrative path, and then put the cost together. And what became real obvious is that we were working in many different worlds. You've got the hospital world, the physician world, the vendor world, the pharmaceutical, and the insurance. And they've got to all come together in some way. And I think it's very easy to when you're working in the areas to only think about your side of it. And you need people that will bridge the gaps. And that was something that came probably very naturally to me. And I'll talk about how the Medicare project that I ended up working on really changed sort of the whole scope of things. If you go to have surgery, you're going to get at least five different bills. You're going to get a hospital bill, a surgeon bill, radiology, pathology, any consultants. And those bills are very separate, and you're trying to figure it all out. The Medicare project I worked on, which was groundbreaking and still is to this day, bundled it together. And you came up with one price. So all of the provider entities, the hospital and the physicians, were at risk together, which doesn't happen right now. When you look at the way, if you go to surgery or if you go in for a medical situation, everyone's economically working in a separate silo. So when you put the bill into one group, then all of a sudden, you've got to make sure that you're using your money wisely in order that everybody's going to get paid.
Okay.
And then from that, what became real obvious is you need incentives, no different than you work with incentives in any business. Like you have goals, and if you go above those goals, you might get a bonus. So I tried to come up with a model where you would be able to pay the physicians for better quality and lower cost. Well, it turned out it was 100% illegal for hospitals to work with physicians. So that in itself is one of the reasons we've had a lot of trouble in healthcare, is the laws actually keep hospitals and physicians from working together.
Right.
So I took the model that I wanted to do, and attorneys kept saying, no, you can't do it, you can't do it. So I said, well, how do you get around this? And they said, either you get the law changed or you get the Office of Inspector General, the OIG, to say you could do something. So I went to the OIG and I submitted plans of what we wanted to do. And everyone really thought that was absolutely crazy because you don't want to go to the OIG. They'll arrest you for doing the wrong things and put you in jail. But it was like, no, I'm trying to do a plan. We're not going to do it if you don't tell us it's okay. And it turned out that I was able to get 14 opinions approved through the OIG. No one else could do it. We were able to do it because we were able to measure things. We had a plan. We understood how to integrate the physicians. And that became so much of an issue that I ended up having to testify in front of Congress about what we were doing. Because what happened is there was so much misunderstanding about cutting cost. Because when people say in healthcare, you're going to cut cost, what they think you're doing is cutting quality. Right. And the honest truth is, if you cut quality, your costs go up because you have more complications.
Right.
So if, let's say you've gone to surgery and you end up with an infection, that's a complication. So your costs are going to go up. So what we were trying to do is incentivize the cost to go down and the quality to go up. But right. It took getting in front of Congress to actually get a large enough audience, not just the congressional people, all the people that had complained about what we were doing, all the vendors were very upset about it, for them to see that there was actually a way to come up with a model that would decrease cost and improve quality. Yeah. So that became the jumping off point. That model worked so well, but what has changed now that's going to affect everybody going forward is costs have soared. And they've soared because our health is worse than it's ever been. So now we've got younger and younger people with more health conditions than we had 30 years ago. We've got technology coming out, new pharmaceuticals. And if you look at where we are in the cost, I actually wrote this number down because it's so significant. In 1990, we were paying $725 billion annually for healthcare in the United States. This year, we're at $4.9 trillion.
Oof. Quick math, that's a big increase.
Yes. And now think about what everybody who is insured, what your company is doing right this minute. They're getting the new premiums for the next coming year. And with the cost soaring every year, that's coming back to the businesses, back to the employees, back to the families. And then it's growing at a level that the trillions are growing so fast that we are in big, big trouble going forward.
Yeah. Any idea on like what's that trend looking like? I mean, do you have an idea what next year looks like?
If we're at 4.9 trillion, the estimate is in 5 years we're going to be at 6.8 trillion.
Golly.
Okay. One of the things that have grown is dementia in a big bubble has grown. Cancer has grown in a level that needs to be very, very frightening. The weight loss drugs, the jabs that people are taking. I read a statistic the other day that's going to add $4 to everybody's premium. That's one drug that only a small percentage of people are using, but it's expensive. The average cost to bring a new drug to market is $1.3 billion. Wow. And it's a 10-year process.
Mm.
So
you've been in this. You testified in front of Congress, right? So that kind of gives you a lot of clout in this. But like, what do we need to do? And maybe it's not me and you, but what does government need to do? What does the healthcare industry need? Like, what has to happen for this to? And I'm not gonna say it's gonna ever go down, but like to slow it some to get us, because people still want to be skinny. And and
the reason they've been paying for it is they're hoping like less people have had diabetes, like all the complications that come with weight is what they're looking at and everything. And so but it's sort of one of these things that you start realizing that it's a different experience than we used to have, where we are right now.
Yeah. Are people generally sicker than they were, or
yes,
are they going to the doctor less? Like, what is it? What are the things to triangulate around to get to this? What the real problem is?
The baby boomer population is one problem because it's a greater number of people. But believe it or not, that part was probably accounted for more, where they're saying the greater numbers is like back in the 90s. I think it was only 10% of children were diabetic, maybe even less than that. Now that number is much, much bigger. So you're starting even at children level that we're seeing. And the nice thing is there's finally some talk about what's going on, and there had not been much said about all of this until recently. So we're definitely sicker than we've ever been in the United States. And so that's a cost thing. The second thing is that I've heard that people are starting to look at is regulations, because the fact that a new drug takes 10 years to come to market and has that is pretty unsustainable. And there's a lot of drugs that start that path, and that wasn't in the statistic, that spend billions of dollars that don't make the cutoff. Something happens in the trials or whatever, and they don't work, but it's still a cost that has to be recouped. So those type of things are going to have to be looked at in a way that we're not doing right now.
Yeah.
Yeah.
If you had a magic wand, what would, and you could point it at, something or some things to, like, if we could cut this cost, if we could cut this waste, if we could trim this fat, this is what I'd point it towards, and it would make a measurable difference. Like, what would that be? It could be one thing, it could be three things. But where are we need to be focusing on?
Yeah, I would want to trim as much regulation as possible, and not just like in bringing drugs to market. And you might hear it from a lot of the staff that you guys do so much work with through your company. There is so much documentation and so many things that don't seem to be helpful. They're not. Sometimes if you check out as a patient, you can get 20 pages of printed material that nobody's going to look at, but it's a regulation and it has to be done. So to me, the regulation part needs to be looked at, because you don't want to stop technology, but you've got to find a way to not make it so expensive. The other day on a program that I was listening to, they were talking about, that the studies that, we've done in the United States and everything. Well, we actually fund the burden of the cost for the whole world. And that gets into another whole topic. It's like what we pay in the United States for drugs is much more expensive than any other country. And what you find is, like, one example may have been the insulin. Until recently it came down, and they did specifically the insulin because they knew that a lot of people were complaining about it and upset about it. But a lot of people, believe it or not, were getting their insulin out of Canada. So, it's when you look at that you can go to another country and get the drugs, you've really got to wonder, okay, is this sustainable for the United States? Because it's not coming from one pocket, it's coming from everybody's pocket. And as we look at the growth curve of cost, we've got to turn around and say, look, this whole thing needs to be looked at. My biggest fear is that government has a very hard time making changes. And as things turn over and everything, it's going to be very, very hard to step back. It's like trying to change the oil while the car's moving. It's a very challenging situation.
Yeah. And it feels like, from just a human being living in this society, that the insurance companies, the drug companies, everybody in healthcare, like, they've become used to a certain level. And how do you say, now we're going to pay you a bunch less to be like, they're uncaring as an organization that, like, that it's, they've got to maintain their profits. They've got shareholders. They've got, equity holders that want their money the same way that, and the only way to do it is by, I think exploiting is probably too strong a word, but, by retaining these levels that, you can't back down from.
Right. The insurance companies, I think, are probably the most misunderstood from what I hear out and about from people. The insurance companies truly are trying to manage that finite amount of money, our premiums. And when you look at what comes their way, there are treatments now, one-time treatments that are $500,000 for the drug, $500,000. And those treatments work, and there's so many studies to expand it. beyond where it is. And I'm thinking to myself, $500,000 for one drug, one dose of the drug.
Yeah.
And I look at the insurance companies and I think they're really in a no-win situation because the technology's coming, we're getting sicker, and it's really not their fault. I look at the pharmaceutical industry and I think, what you were saying is absolutely right. They've got to recoup their costs. They've got their shareholders. They've got to justify what they're doing and everything. So it's like, how do you bring it all together and figure it out?
Yeah.
One of the things people talk about all the time is we should be 100% covered by our government. Well, what nobody realizes is when Medicare pays hospitals, physicians, and everyone, they can't make it on what the Medicare payments are. Medicare payments are not enough to keep the doors open for anybody.
Right. Yeah.
So the insurance companies are the ones making the difference. So when the level of issues we've got to try to figure this out is significant, and you don't see sort of like what you see is people talking about the problem, but there's not a lot of answers that are out there.
Yeah. I want to get your opinion. I've seen a few articles about Mark Cuban's, I think he calls it Dollar Pharmacy Club, Dollar Pharmacy or something.
Yes.
I don't know what he calls it.
Yes.
But he's trying to lower costs and, generics and all that kind of stuff. Do you think that that's sustainable, or is that something that, even a guy like Mark,
in a way, and there's a couple other those models, and it, even if you've got drug cost insurance and everything, you can go into those models, and his is one of them, where it's even a little bit lower, and that does make a big difference for people because back in the 90s and even in the early 2000s, we were not paying a lot out of pocket for drugs, for hospitalizations, or anything. Now the dollar amount keeps going up, up, up. So any dollars anybody can save make a difference. And to me, what those models are the true supply and demand models. Like if they can figure out somebody has that generic and can sell more of the generic, then they're going to give Mark Cuban that good price and everything. And that's the kind of thing that's going to help the customer, the patients, be able to survive through this. That's going to be real important. The other thing that I know, and your company does a lot of, is telemedicine. Telemedicine lowers the cost of the facilities that you're in, and it makes the physician's time better and different things like that. So that's a big breakthrough. And it's growing in what you're doing and everything. So those are great examples of where you're trying to get ahead of the curve, that the old models just are too hard. One of the things, is the amount they make physicians document. That's got to be looked at and stuff.
Yeah. As we've seen on the nurse space specifically, like nurses aren't quitting for other jobs per se. They're quitting because they don't want to deal with everything that comes with being a nurse anymore. This chosen profession of theirs has seemingly like kind of turned their back on it, on the nurses, to say, and they don't, a lot of these nurses don't feel safe. They don't feel heard. They don't feel, they don't, there's not, they want to grow into a position, but they get stuck in, and eventually they just leave the profession altogether. And that's where if we could retain the nurses that we have going forward, we could keep nurses, and that nursing, the shortages kind of go away. I
think you've hit on absolutely everything you've said. Could not be more on target on how the clinical staff are feeling. Very much so, and they can't find a voice. I think you're right. It's a big problem, and it's there's no good answers even in that area. So that's the part is you see this great technology coming out, great new pharmaceuticals, great new technology. But that other part that you deal with every single day is so critical to keep that going.
Yeah. Yeah. One of the things you mentioned was the importance of I think you said costs. The thought is if cost goes down, the quality goes down. And I think that's across the board something in healthcare that we're going to have to change how we view things, because I've even heard it on the staffing side. It's we can make the cost go down. HWL, the cost can go down because we're centralizing how we do things. We're making it one smooth process with one contract, all that kind of stuff. And the costs go down. Well, does that mean the quality is going to go down? Well, no, because it's making things work better. Ultimately, will have, even if it's not a line item you can see on a budget, it's going to reduce costs. But also, if you can streamline how you use something, you will see actual cost savings. But I think from a healthcare standpoint, this idea that if it's cheap, it's bad, and or
if we say the word cost cutting, and that was what we faced when we started that project from Medicare. We actually ended up on the front page of the Wall Street Journal. That's how high profile negative that was. You don't go on the front page for good things. You go on the front page for bad things. And it was exactly that. And that's why they made me testify in front of Congress about what I was doing. They thought I was harming care and doing things that were bad for patients. So that perception's there. Matter of fact, as they've talked about trying to look at some efficiencies in the FDA and everything, there's been so many people going, you can't cut anything. Well, that's not true. We're not going to survive if we don't look at where we need to go. And so it's really a mindset that's been in healthcare from day one. Believe it or not, until 1980s, hospitals were paid their cost plus. So whatever their costs were, it didn't matter what it was, they got cost plus their profit from payers. And then that changed in the 80s. And the biggest thing that has been left out of the scenario, in my opinion, I think coming from a clinical background, and when I was in hospital administration, I was very aware of the clinical side. But a lot of times the people managing things think of the hospital as one entity, and it's not. You've got to look at staffing in each entity. So if you're in one part of surgery, you need something different than another part of surgery. You can't say across the board, you got to do something like make a cut by 50%. And we've seen that over and over again. And that's how, to me, the staff are not being heard. And it's not just the nurses, it's the physicians, it's the technicians, it's everybody across the board. Feel very, very much like no one's looking at the clinical side of what they're trying to do. And yet they've got the power to make it more efficient if somebody set it up right for them.
Yeah. No, I think that's a great point. It's all about how you set it up. I often say, if people would just get in a room and we're not going to leave until we solve this problem, then we can finally get somewhere. But it's all just emails and a committee meeting here. It just ends up But there are problems that we need having solved right now. And you mentioned it. It's cost plus drugs. You said cost plus. It's not dollar. That's the Dollar Shave Club. But same idea. Cheap. Cheap pharmacists. All right. Well, John, I appreciate you joining us. We've got a couple minutes left, and you have two incredible sons, but one of them is an author and also a speaker. I'll give you a minute just to plug what Michael's doing, and if any of our audience is interested to go buy his book or book him for a speech, that would be great, because I've seen him speak.
Yeah, thank you. Thank you for even mentioning that. My oldest son was born in 1987. And when he was 4 years old, he was diagnosed with low functioning autism. And when he was diagnosed, it was 1 in 2,000 children. Today, it's 1 in 33. So we were facing something that nobody really had a system for. They said he could not go to school. He could not live independently. He ended up graduating from college, got his MBA. He works as a data processor. The book came together after he did some talks that really people said to him, "You've got to write this down. It could help so many people." And so his book is What Autism Gave Me. And he actually speaks to all kinds of audiences. It's motivational. It's really like, if you get stuck, don't give up. There's always a path to the next step. And he has, I think, been able to help many different types of people who really thought, they couldn't go forward. He's had notes from teenagers that just were depressed and just didn't feel like they could take a next step, that said that his story really helped them. So it's not as much about autism as it is that if you don't give up, there's just many paths for everybody. Yeah. And I think it fits for today.
Well, good. He's an incredible young man. So I'm lucky to know him, and happy to make sure that people know about his book and that he's
thanks for bringing him up. Yes.
Yeah, no problem at all. Joan, thank you for coming. Thank you. I don't think this is going to be the last time we're going to talk to you. You have a wealth of knowledge that as things keep changing in healthcare, you're right at the top of the list of people knowing what's going on with healthcare. Thanks. And I appreciate that about you.
Well, you guys are doing an amazing job. You're into everything that's important. And
well, I appreciate
maybe if you guys got into the cost side, it'd move some.
Well, we'll tackle one problem at a time, but that's right. But I appreciate it. Just want to say thank you to the audience. Appreciate you joining us today, and look for another episode coming out shortly. We've got a lot of great guests on the horizon. And lastly, just want to thank Joan. Thank you for being with us, and we appreciate all you're doing and all the information you provided us today.
Thank you for the invitation.
Thanks, Joan. Have a great day.
You too.
Bye-bye.